My name is Dr. Hetty Carraway, and I'm here to talk today about some of the updates from ASH 2020 on myelodysplastic syndromes. I currently work at the Cleveland Clinic. I'm a physician here and treat patients with myelodysplastic syndromes and acute leukemias and other myeloid neoplasms, including bone marrow failure states like aplastic anemia and PNH. I'm the director of the leukemia program, serve as the vice chair for strategy and enterprise development, and also I'm an associate professor. Thank you for joining me today. I'm going to walk through some highlights, including kind of talking about the impact of next generation sequencing and the techniques of specific tests that help us to better diagnose MDS and differentiate it from other disease entities. And just to highlight some of those things, just some of the investigators and the work that they did and presented at ASH this past year. Some of the profiles and the mutations that we identify in these disorders help us to better understand the disease of MDS and differentiate between lower risk and higher risk MDS. And finally, we'll have the opportunity to touch on some of the data that was presented with regard to combination studies for patients with higher risk MDS and some of the novel therapies we'll just touch on in the patients that have lower risk MDS and some of the novel drugs. With regard to MDS, I will remind you that we use specific data, whether it's the blast percentage, the number of cell lines that are affected, and even the chromosome tests from someone's diagnosis to help us understand, the risk of progression of that disease. You might imagine that we're more interested in understanding that if we can detect the disease earlier. And so many of the efforts that were reported at ASH this year by a multitude of investigators includes using mutation testing in patients at earlier times to help us identify and diagnose kind of earlier entities such as age-related clonal hematopoiesis or clonal hematopoiesis of indeterminate potential, or just earlier entities that may then put patients at risk for a diagnosis of MDS later on in their life. And much research is going on trying to think about what are some interventions that we can do to delay the progression to myeloid neoplasms. So work was done kind of looking at specific mutations at earlier time points to help really classify, is this MDS or is this from some other disease? We also are improving our methodologies and including mutations as part of the analysis in terms of having the ability to detect whether or not someone's MDS will be a lower risk versus a higher risk behavior based on the presence of mutations and other factors, and putting all of that into a modality and using tools like artificial intelligence. Some work was presented with regard to that, and we continue to move the needle to improve our ability and our accuracy in terms of who's most at risk, and if so, what interventions can we deploy. I will say that's an exciting piece of what we know to be happening in MDS, and specific to mutations in general. The majority of mutations are known to be associated with a poor or a worse outcome, except for one mutation in particular, SF3B1, tends to be a mutation where patients tend to do better and the disease does not progress as quickly. And so there's a lot of effort trying to better understand that particular mutation and why it's associated with something called ring sideroblasts. And so work by Klopp et al. Looking at abstract 411 was really kind of exciting and a deeper dive into some of the understanding of that particular mutation. There's specific things that are being done trying to better understand poor risk mutations like P53 and using mouse models to better understand particular sites of disease and how those particular mutations relate to cancer growth and kind of the messaging of that. So that was also an exciting presentation that was done by Dr. Ahmed out of Washington University, or WashU. For many patients, they're interested in what are the new therapies. And for some of you listening, you probably already know that there's a new drug that was FDA approved in April of 2020 called luspatercept. And so that was a very exciting addition to the armamentarium for patients with lower risk MDS. Another drug that is of interest and was presented this year by Dr. Potzbacher et al. At ASH was a drug called imetelstat, and that's a first-in-class telomerase inhibitor, and it does appear to have selective killing of malignant stem and progenitor cells. It enables normal cell blood production. And so this particular study that Dr. Potzbacher presented described 38 patients that received imetelstat. And of these patients, there was a nice response in terms of improvement in transfusion independence for red blood cells. So about 42% of patients had the onset of transfusion independence when they were on this clinical trial. And so for some of those patients, that also, there were 32% of patients that had a 24-week duration of transfusion independence. And for 29% of patients, they had enjoyed 1 year of transfusion independence. For patients on this drug, there appeared to be pretty good durability of the response of transfusion independence. So 29% of the patients that achieved transfusion independence were transfusion independent for at least a year. And there was no real concerns with regard to a safety signal for most of the adverse events. Patients had, cytopenias or low counts, but those weren't really associated with significant clinical consequences. Other interesting data that was presented at ASH with regard to patients with higher risk MDS are really asking questions about what are some agents that we can add to hypomethylating therapy, whether it's azacitidine or decitabine, to improve the response rates, overall survival and durability of response, and also even transfusions. So combination studies really were a hot topic for ASH this year with regard to high-risk MDS and even some of the AML, CMML patient categories. One of the first combinations that I'll talk about was data that was presented by Garcia et al., looking at combination azacitidine plus venetoclax and trying to identify the best dose of venetoclax for patients with higher risk MDS. This study presented 78 patients, and those patients appeared to have a nice response rate, had an acceptable safety profile, and appeared to have improvements that were clinically meaningful, such as improvement in their shortness of breath, improvement in their quality of life, and improvement in their fatigue. For those patients that were able to obtain a remission, they did seem to have improvements in their symptoms. And so with this study that was presented, they were able to find a recommended dose, and they're moving forward with enrolling patients in a phase 3 study with azacitidine and venetoclax. Another agent used in combination with hypomethylating therapy is a TIM3 inhibitor, TIM3 inhibitor. This study actually combined the TIM3 inhibitor with decitabine and also had a cohort of patients that combined this TIM3 inhibitor with azacitidine. So this agent is called sabatolimab, and it was used in combination in patients using or receiving decitabine, and that was studied in, almost 20 patients, and the same was true for patients that received sabatolimab plus azacitidine. So these two combinations, sabatolimab plus decitabine and sabatolimab plus azacitidine, was studied in high-risk MDS patients, de novo AML patients, and also in patients with CMML. The largest subset were those patients with de novo AML. There were 48 patients that were studied, and there were 41 patients that were studied with higher risk and very high risk MDS. So data from this combination also was quite promising in that the overall response rates for these three populations were 64%, 41%, and 54%. So pretty exciting. With regard to the toxicities, also very well tolerated and appeared to have a nice duration of response. Again, because of these data, this is now leading to phase 3 studies and other phase 2 studies that are ongoing using sabatolimab in combination with hypomethylating therapies in patients with higher risk MDS. And finally, one other phase 2 study that I wanted to mention was combination therapy with azacitidine and an agent called pevonedistat, and pevonedistat is a NED8 activating enzyme, and this blocks some of the proteins. And so using this combination, we were hopeful that this combination would actually improve response rates in patients with high-risk MDS. And so this work was presented by Dr. Sekaras and described 67 patients that had received combination therapy. Again, some patients received the combination pevonedistat plus azacitidine, 32 patients, and in the azacitidine only arm, there were 35 patients. So they compared the outcome of these 32 patients with the outcome of these 35 patients. Again, the arms were quite balanced, and it did seem that the EFS and overall survival in the study was improved for those patients receiving combination therapy. And in addition, the complete remission rate was about twofold higher in the combination arm, and the median duration of response appeared to be about 3 times higher in the combination arm compared to single agent azacitidine. When they looked at transfusion independence, it did seem that there was a higher transfusion independence rate in those patients that received combination therapy. Furthermore, in looking at time to transformation to AML, that was prolonged or delayed in patients that had combination therapy compared to patients that just had single agent monotherapy. With regard to safety, it was well tolerated. There were not more events of side effects in combination therapy compared to monotherapy, so it was well tolerated, and it appeared to help a broad category of those patients with higher risk MDS. And for that reason, this study was also quite exciting, and people are eagerly awaiting the outcomes and the results from the phase 3 study comparing combination therapy to monotherapy. So with that, I will wrap up and say, we have novel agents now in our patients with MDS that are both oral therapies, such as oral hypomethylating agents that are new and approved in the past year, as well as novel agents such as luspatercept, and now combination therapies that we're thinking about combining with the HMA or hypomethylating therapy backbone. So we're at a really exciting time where we're going to be seeing combinations of agents together to try and improve the outcomes for our patients with MDS. So I think it was a very exciting year, and I think more is yet to come in this coming year as the results of these phase 3 studies emerge. So thank you for joining me. Please attend some of the other presentations done by my colleagues that will enumerate some of these details further, but I'm so grateful that you joined me briefly for this short recap.